also from Henry Ford Jackson Hospitals, Vice President of Population Health, Dr. Cortland Keteyian. Welcome back to the show.
Thank you.
How's everything? Let's talk about what we've talked about for the last 2.5 years. COVID. What's the state of the
Current
disease at our hospital?
So we've been pretty stable now with 10 to 20 people in the hospital at any given time for the last couple months. That's been pretty routine, and a fraction of those, 2 to 3 of those end up on a ventilator. It's still basically every week at this point somebody's dying of COVID.
Every week.
Every week, yeah, every week. We can track the county health department keeps those numbers, and so you can see, and most of those are at the hospital in Jackson. So, so it's still present, and it's become routine. I mean, I think we just expect we're going to have 10 to 20 beds that have COVID patients in them, and we're going to have people that are dying of COVID. So that's what we expect. And so, I mean, I think in context, the hospital is just shy of 300 beds, so we're using somewhere between 5 and 10% of the beds for COVID patients at any given time, and we'd rather not be, but that's what it is, and we'll take care of people if they're there.
So we've become hardened to these numbers, really. Yeah. I think it's like, can you imagine? 3 years ago, if there was something that every week 1 or 2 people died in the hospital from something, we wouldn't believe it. And we've had weeks where we've had 5 people die. Now, early in the first year or so, people died that were healthy, otherwise young, healthy, 43-year-old guy, normal, everything's fine. Suddenly, COVID dies.
Yeah.
Have we seen a change in that? The people that are dying from COVID, do they have comorbidities?
Yeah. Yeah. So generally, yes. I mean, I think so as time has gone on, we've developed these different variants, and the Delta so far has probably been the worst. That was the one that hit in the fall or winter of last year. That's when we were losing extra people every day. At that point, we had on average 2 people a day die from about November through the end of January, middle of February. We had 2 people dying every day in Jackson County. That was Delta, and then the Omicron variant. But Delta's been the most severe. It seemed to cause a deeper lung infection. It was more of a pneumonia, whereas Omicron seems to cause more of an upper respiratory infection. As we've gotten these further, so now it's BA4 and BA5, which are subvariants of Omicron. BA5 in particular is about 85% of cases in the U.S. now. And that does seem to make people a little bit more sick than sort of the original Omicron variant did. It does seem to get a little bit deeper in the lungs. So the infection rate's relatively low right now compared to where they were, back over the winter. But it is kind of cause for concern that we have a variant circulating now that's potentially a little more virulent than it was, with Omicron previously. And now we're going to hit the time period. I mean, as soon as kids are back in school and we are inside more, I think we're going to see cases tick up again. It's been a little hard to track, whereas we used to be able to rely on, kind of health department data to say, okay, how many cases do we have in the community? You can't really do that now because there's a lot of folks that don't get tested. So you don't know what the really kind of true burden of cases are in the community. One thing they've been doing that's really interesting is there's been wastewater sampling. And you can actually sample wastewater in the city of Jackson. A number of cities in the state are doing this too, that have treatment facilities. And you can look for genetic material from coronavirus in wastewater. And you can use that to assess for kind of the burden of disease in the community. So if you compare like right now, and there's about a 2-week delay actually, but basically middle end of July now to other times of the year, it's about the same now in terms of our prevalence as it was probably like last October. And then obviously we had a really big spike that happened into November and December. So we'll have to see, but I think that we should expect that we're going to get a lot more cases as we hit the end of August and September when kids are back to school.
Wow, I didn't know that was happening here in Jackson.
It's pretty cool.
Yeah.
I'm not sure who came up with that, but it's a pretty slick idea.
Well, I remember probably in the first couple of months there was a college in upstate New York that was able to, because they had a treatment facility on campus, they were able to measure, and I think other people caught on.
Yeah. University of Michigan started doing it last year as a way to kind of track, and so it's actually through U of M that the state's been working with to kind of do this in other communities. So it's pretty helpful, actually.
So what do we know? What has that produced as far as results so far?
Well, it's basically, you can only kind of compare because the numbers are different, right? It can't tell you like how many people are infected. It's just telling you like within the wastewater, what's the concentration of genetic material. So you can compare concentration now versus what it was at other times. And we can kind of overlay that to when we had really big spikes, right? So you can see back in December and January, there was a lot of concentration in wastewater. And then it really trailed off into like, April and May. And then we've seen it tick up again over the summer. And then the question is going to be, does it continue to climb as we get into the fall?
Well, more accurate than the reporting of testing results, because people are getting tested with home testing kits.
Yeah, and those don't get reported, right? And a lot of people don't get tested even with the home kits. They just, it's like, well, I have a cold. I don't want to, I don't want to know.
They don't want to know. I don't want to know.
Yeah, it's better to know, because if you know, then you can help keep other people safe. If you don't know and you're kind of going about your business, then you can affect other people. And I think, this idea that, it's just a cold, right? It's not a big deal. I'll get over it. You really have to assume right now that if you have a cold, it's COVID. So you really should test for that.
Now, at what point should you seek medical help in terms of the Paxlovid?
The Paxlovid, yeah. So if I'm anybody that is in an age group or in a risk category, so I mean any really kind of chronic medical problem that people have, folks that have diabetes, people that are on drugs that suppress their immune system, like steroids, those people really should, they're going to have a doctor that's helping manage their condition, but, those people really need to consider getting treated with Paxlovid. And folks that are older, 60 and over, really should be, the risk of a bad outcome, meaning hospitalization or death, goes up by orders of magnitude as you age, decade by decade. So over 60, really, people should be strongly considering Paxlovid.
So I would. If I got it, I'd go. And is it true the pharmacists can actually prescribe?
They can. There's quite a bit of rules around that, so I haven't really seen that implemented in practice like very successfully. They still have to do it with a collaborative agreement with a physician. So the state's trying to make sure that when people, it's really been underprescribed. So the state's trying to give access to people, right? And that was one way they were trying to do it. I think we've gotten pretty good at the community. We've worked really hard educating the doctors around when to give it, when not to give it. There can be some interactions with other medications people take. So if they're on statin medications for their cholesterol, for instance, or they take medications for seizures or things like that. So those have to be kind of negotiated. So you really want to have a physician involved if you're taking other medications, so there's not an interaction between the Paxlovid and those other things.
It'll be faster if you ask your doctor than if you go to the Eastside Meyer pharmacy drive-through. I guarantee it. So the current vaccine, we know it's going to be replaced by an updated version. Should we wait for that booster if we're due?
Yeah, I think that's a really good question. So I think for people that are eligible now, so let's say that they've had their primary series and they're eligible now, it's been 4 months and they're eligible now for their first booster, or they've had their second booster and they're over 50 and so they're eligible now for their second booster. I would just get it. I would get it because there's enough activity in the community happening right now that it's better to be protected now than it is to wait. Because nothing's a sure thing, and the new vaccine is it's essentially the old vaccine plus they're adding in the new Omicron component. So originally there was the genes that code for the spike protein, the part that gets the virus into the cell. That was what's in the original mRNA vaccines. And so now it's that same instructions plus those instructions for these new Omicron variants. So it's called the bivalent vaccine because there's bi is two, so there's two, sort of two strains or two runs of mRNA that are included in this vaccine that are injected. So it still has protection against the original virus, but it's also adding this protection to the new strains that are out there circulating.
So the vaccines that first came out, Pfizer, J&J, Moderna, everybody couldn't believe, wow, miracle. Where's the rest of these companies? I was expecting, there's going to be 8 or 10 other companies with vaccines that are even maybe better tested. We'll be seeing.
No, that's a good question. I think that what happened is I think these are business decisions. I think that there were other companies that had vaccines in development that weren't as successful as these, so they abandoned development. So because these have been so good that others kind of gave up that ambition, but there's 4 available now. So there's Pfizer and there's Moderna. Those are the 2 mRNAs. There's the Johnson & Johnson vaccine, of course, which is different technology, but it's been around as long as the Pfizer and the Moderna. And then there's a new one that's just becoming available called Novovax. And Novovax is interesting because the technology, it's the same type of technology that's been used in other vaccines that we've had for years and years. And there were I think a number of people nervous about the mRNA vaccine and worried that it was new and so they didn't want to try it. The Novavax is basically the same thing as like a pneumonia vaccine or a tetanus shot, or it's basically proteins that are being injected, and then your body makes an immune response to the protein. So it's the same as a lot of other vaccines we have on the market right now. So some people I think feel more comfortable with that and are more likely to get that one.
It's got a better name. Novovax.
Novavax, yeah.
I want the Novavax. People are getting COVID every day in Jackson, and people are getting it that had never had it before.
Mm-hmm.
And those are the people who said, well, it's been 2.5 years, I have not had it, I'm lucky, I'm predisposed to not be susceptible to the virus. They've proven themselves wrong. But is that a possibility? Are there people that, if they haven't had it by now, they're not going to get it?
I guess anything's possible. I think it's just based, a lot of it's based on the environments you're in and how exposed you are, right? So if you're somebody that, doesn't go to big public events very often, and I think it's possible you could go without getting it. I think what's more interesting, there's people that have had it 3 times.
In the same
right?
week?
Yeah, these new variants, the BA.5, is known for its immune breakthrough. So people that have been vaccinated or even have had COVID already, and it's a couple months later, and they're getting the BA.5 variant.
Yeah, I know people that have had it twice and 3 times. And last month, the president got it twice in 1 week, which to me, it's like, no, it's not twice in 1 week. He had it on Saturday. He just still had it the next Saturday.
So that's a very specific, that's called breakthrough. So, rebound, not breakthrough, it's rebound. So what happened is he got Paxlovid, and that basically improved his symptoms. And he's being tested every day, basically, right? So his test turned negative when he was taking the Paxlovid. When he stopped taking the Paxlovid, he had a little bit of a rebound of his symptoms. And so, and his test became positive again. So that's where people are, they're saying, well, it was gone and it's come back. It's been there. It was just suppressed to a level where the viral load wasn't really detectable in a test. And then it became detectable again. But it gets people through. The Paxlovid is still, because then people say, well, should I still take the Paxlovid? Well, yes, because it's getting through that window of acute illness where you could get really sick and end up in the hospital. And so if you have a little bit of rebound in your symptoms, it can occur up to 2 weeks, actually 2 weeks after you stop the Paxlovid. If you have a little rebound in your symptoms, I'd rather have that than be in the hospital. Yeah. But that's very common actually that happens. That's probably 30% of cases.
Really? So the testing too, they're testing negative, then positive, then negative, then positive. It's just it's ping pong.
Yeah. Yes, it is. Yes, it is. And we won't actually test people. So when we do the test at the hospital, we test somebody once, and we won't test them again for 90 days because it really doesn't. Clinically, there's not a lot of utility in doing that. We know if you had it, you had it, and so we want to make sure you don't get worse, and so we want to make sure you get Paxlovid or you get monoclonal antibody or something that's going to keep you from a bad outcome. But we're not going to keep testing. It doesn't really matter at that point.
Are you testing everybody that comes in?
No, not at this point. There was a period of time we did that. Everybody had to get tested, but yeah, we're not doing that now.
All right, the other public health emergency, according to the state of California and the U.S. government now, monkeypox is an emergency.
Yep.
Do we have monkeypox in Jackson County yet?
We do. We have one case.
One case.
One case, and so for context, obviously, and we're talking about COVID. We're having thousands of cases, right? Where there's probably thousands of cases of COVID happening right now. So for context, there is one case of monkeypox that's been in Jackson County. In the whole country, it's about 7,500 cases. More than half of those are basically New York City and California. And in the state of Michigan, we've had, I think, 72, I believe. And those have been in predominantly the city of Detroit, Wayne County, Oakland County. And we had our first case here just a week ago is when we had the first case here. And that's somebody who's not it was somebody who had contact with someone who was outside the county, basically. That's where the case came from.
Well, it sounds very similar to the beginning of the AIDS crisis.
Yeah.
Very few cases, mostly in New York City, San Francisco, nothing to worry about. But what's the parallel to HIV/AIDS?
Yeah, and people have drawn that parallel, and I think there's people in a variety of different communities who still have some PTSD from AIDS in the 80s, and so I think the parallel there is obviously that this is predominantly affecting the MSM population, so men who have sex with men, and that's where the majority of cases are right now,
including the one in Jackson County.
I believe that's the case. I'm not aware of those details, but predominantly it's been in that population. And it's just based on how it's spread. I mean, it's spread through skin-to-skin contact. It's spread through prolonged exposure to respiratory droplets. So, with COVID, that's spread in a we call an exposure 15 minutes within 6 feet. With monkeypox, it's 6 feet for 3+ hours.
3 hours?
3 hours, yeah. So to spread through respiratory droplets is actually, it's kind of challenging, right? But you have to be really close to somebody for a prolonged period of time. And the other way it's spread skin to skin is through the lesions. So it's monkeypox is the same family of viruses as smallpox. And people get those little lesions on their skin and those shed virus. And so that's where you can get it is from contact with those lesions that are shedding virus. Is
the monkeypox vaccine available in Jackson County?
So it is, and it's only available through the health department. And it's in very, very specific populations where it's used. So right now, and these are all this is U.S. national strategic stockpile stuff, right? There's vaccines for monkey. It's all smallpox response is where this stuff comes from, right? So the vaccine for this, and there's a medication, TPOXX, for it, and there's immunoglobulin. Just like we have monoclonal antibody for COVID, there's basically monoclonal antibody for smallpox, and it can be used for monkeypox as well, and. So there is vaccine available, but it's only used right now in people that have had basically high-risk exposures to known cases of monkeypox.
So it's something that you don't get a vaccine before?
You don't have to. So that's what's really interesting about monkeypox is the incubation period for monkeypox is 3 to 17 days. And so if you vaccinate somebody within the first 4 days after exposure, it's likely you can prevent them from developing symptoms at all. And even if you give it after, days 4 to 14, you can actually reduce the symptoms that they'll experience. So it's very different than COVID. When we talk about how COVID's really easy to transmit. One case of COVID is going to probably infect 7 to 10 other people. One case of monkeypox is likely to infect, on average, less than one other person. So these outbreaks tend to be sort of self-extinguishing when we've seen them over time. That's what's really interesting about this case right now, actually, or this outbreak we're having, is to see the kind of growth in cases we've had, even though on average these tend to infect less than one additional person. If you're less than one, eventually it's gonna run itself out, right? So I think that's what people are waiting to see, is do we see the cases continue to climb, or will they run themselves out?
The morning after vaccine.
That's pretty much what it is. Yeah.
So do you do the contact tracing?
Yeah. So the health department does all that, right?
Wow.
So it's the same thing. And so to even get tested here. So let's say somebody comes in to see their primary care doctor at Henry Ford. Their PCP is going to basically consult our infectious disease physicians, who's going to call the health department, and then it's going to be a decision with everybody to say, talk to us about your exposure. Why do you think you were exposed? What kind of symptoms are you having? Which, by the way, the symptoms are before the rashes: fever, swollen lymph nodes, feeling fatigued. That's the kind of viral, experience people get before they get the rash. So the doctors have to be kind of lookout for that, and then there's a collective decision to say, okay, we need to test for it now, and then those tests go to the state lab. The state lab's the only place right now where you can get that test done in the state.
All right. Well, we appreciate all the information and all that you do for the community. Thanks for coming in.
My pleasure. Thanks.
Good to see you. The Vice President for Population Health at Henry Ford Jackson Hospital, Dr. Cortland Keteyian.